This is Nursing 517-617 Module 1. Let's get started. Cardiovascular disease is a class of diseases that involve the heart or blood vessels. Cardiovascular disease includes coronary artery disease, which we also call CAD, such as angina and myocardial infarction, commonly known as a heart attack. In this module, we will discuss the roles and responsibilities, understand the benefits of the advanced practice registered nurse as a prescriber, clinical judgment in prescribing. The student should be able to facilitate positive outcomes, express barriers to adherence, understand improving adherence, and understand the principles of pharmacology. Why is this course important? Well, advanced practice RNs must have an understanding of disease process, pharmacology, and nursing. You will blend your medical and nursing knowledge to be a successful, safe prescriber. To be a safe prescriber, you will need to understand pathophysiology and the disease process, pharmacology, and rational drug selection. In this course, you will learn the basics of advanced pharmacology. There is no way to teach you everything you need to know about pharmacology in one semester. It will be your responsibility as a prescriber to always continue your research and lifelong learning of medications and principles. New medications are continuously added, and FDA continues to remove medications and add black box warnings. As a prescriber, you are responsible for keeping up with the changes. Your license will depend on it. So, you must have advanced knowledge, use good clinical judgment, collaborate with other providers, and stay current with issues and trends. The Louisiana State Board of Nurses, which is also LSBN, regulates the practice of advanced practice registered nurses. Scope of practice is regulated by your nurse practitioner license. So you have to understand the difference in the two. So when we're talking about clinical judgment in prescribing, before you pull out your prescription pad, which is old school because now everything is done by electronic health records, but you need to ask, is there a clear indication for drug therapy? Does someone with a cough and nasal congestion that comes to you after they've had it for 2 days need a prescription for an antibiotic? Is there an indication for an antibiotic or a cough suppressant? So you need to kind of know what is there an indication? We're not just going to write prescriptions just to write them. You need to know what drugs are effective for which disease. So should I treat an infection with an antifungal? You may not really know the difference right now between infections and antifungals, but you definitely will by the end of this course. You also need to know which antibiotic is effective for treating a urinary tract infection. And so, should I use penicillin? Should I use Bactrim? Can I use, what's another one? Cefzolin? Should I use doxycycline? So you need to know those things. Do all antibiotics target the bladder? That's what we'll learn in this course. What are the goals of therapy? Am I trying to lower a patient's blood pressure or blood glucose? Are we treating a mood disorder and trying to stabilize their mood? Are we monitoring to see if the drug we have chosen is meeting the goals? How do we know if a medication that we have selected to treat diabetes is actually helping to lower their blood glucose over time? Will duplications in the medications the patient is taking cause an adverse reaction? So you need to know what medications the patient is taking. Be aware of patients with polypharmacy, which often happens when they are seeing more than one provider. I recently had a patient in mental health who was receiving medication to treat her depression from her PCP. Well, if you don't reconcile your patient's medications each visit, you can run into a lot of problems for yourself or create deadly consequences for the patient. Realize your sources of information. Do you have a reliable source or historian? When selecting a medication, are you using evidence-based information? So these are all things you need to consider. Is there a clear indication for the drug? What drugs are effective for the disease I am trying to treat? And what are my goals of therapy? And do I prescribe a medication and just send the patient on their way and never see them again? Or do I need to monitor to see if that drug is meeting the goals? Check the patient's medications to make sure there's no duplications. And you also want to know about their over-the-counter medications versus their prescriptions. Consider the cost. All patients can't afford all the newest meds. I mean, we like to prescribe the newest medications, but realistically, everybody can't afford that. So you also have to factor in the cost. And then know your source of information. Do you have a reliable source? Does your patient actually know what their medication list is, what they're taking? You will also collaborate with other providers and pharmacists regarding prescribing. So you may send a prescription off, and you may hear something back from a pharmacist because maybe you wrote it or typed it incorrectly. Maybe there's a really serious adverse reaction or drug-drug reaction that you didn't catch. Historically, there have been some issues in the nurse practitioner medical doctor relationships. There's different perspectives on prescribing. Know that pharmacists are experts in pharmacokinetics and pharmacotherapeutics. If you ever have questions, call your local pharmacist. They are very smart and they know all of these interactions. They're highly trained. Lean on them if you need them. So one thing we definitely want to do is facilitate positive outcomes. Okay, and I don't know why my screen is not coming up. So when you're facilitating positive outcomes, you want to monitor adherence and know intentional versus non-intentional non-adherence, because everybody who is non-adherent, it may not be something that they have control over, and we'll talk about that. You're going to be aware of adverse drug reactions, any kind of asymptomatic conditions, any kind of chronic conditions. So if you're in family practice, it's very possible and highly likely that you will have patients with chronic conditions, several comorbidities, and you have to manage all of that. Does the patient have a knowledge deficit? Is there maybe some kind of cognitive impairment or psychiatric illness that causes them not to understand about the medications that you are prescribing? No barriers to adherence, because again, everybody's is not intentional. Some complex drug regimens are barriers to adherence. So you may prescribe a medication and tell your patient, okay, you're going to take this 3 times a day. That may be easy to do for someone who is younger and has the time. Maybe it's hard for them because they don't have the time and they don't have time to take a medication 3 times a day. Or it may be a geriatric patient and you're trying to give them a medication 3 times a day and they can't even remember to take it once a day. So that could be a barrier to adherence. Polypharmacy, they have too many medications. Maybe they have sensory or mobility challenges. Maybe they're too young. And if somebody doesn't give them their medication, they can't take it, right? There could be financial issues. Yes, that's a barrier to adherence. I had a patient recently who came in to see me for mental health, and he was losing his insurance and he was worried. He was in tears. What was he going to do? He wasn't going to be able to afford that medicine. Well, he may not be able to afford the latest and greatest medicine, but the old tried and trues work very well, and most of those are on the Walmart $4 list. So you have to be knowledgeable about where can you get medications for patients who can't afford it. There's also many patient assistance drug programs that you can look into, but understand, get to know your patient. And before you write this prescription that's going to cost them $1,000 a month, you can write it and they may take it. And when they get to the pharmacy and realize how much that medicine costs, they're not going to get it. And they're not going to call you and tell you they didn't get it. When they come back and you're monitoring, you're all excited, waiting to see how this medication worked, and then you find out, oh, I didn't get that. That medicine was $600. I couldn't afford that. So they didn't call you to tell you. You didn't know. You think they're taking it. They come back in a month for a follow-up, and they never even changed the medication because they couldn't afford it. So that is a barrier to adherence. So how can we work to improve adherence? We can give longer acting medications. So instead of giving a patient a medicine that they have to take 3 times a day, maybe we look into giving them something that works the same that they can take once a day. Use reinforcements. Caregivers, talk to them because maybe it's a geriatric patient and they have an adult child that is still bringing them to the appointments. We'll talk to them about helping out with their parents' medications. Simplify the regimen. If you can take away some medications and not have them taking 10 medications, but still get the same therapeutic effect, that's a great idea. And definitely follow-up visits. Like I said, you can't just prescribe a medicine and then send them away and okay, it's going to work real good and I'm never going to see them again. No, because you are still responsible for them. So you want to schedule follow-up visits so you can make sure and you are monitoring. And that is a way to improve adherence. So how do we measure adherence? Well, what the patient tells us. Are the symptoms improving? Are they feel is their blood pressure coming down? Is their blood glucose coming down? Are there scales you're going to use to see if maybe that is an improvement? Okay, now we will move on to the principles of pharmacology. Pharmacology is the study of drugs. That's what pharmacology is. And new drugs are coming to the market. There are phase 1, 2, and 3 clinical trials and approval by the FDA before they are cleared to hit the market. So all of these drugs, when you start seeing commercials and they're coming out, these drugs have been through trials. It's not just a company who says, I'm going to make this drug for depression, it's going to work real good, and here it's on the market. No, it goes through several trials. Popular weight loss medication, Ozempic or Wegovy, that went through several trials before it actually hit the market, and it's still not perfect. So, but before the FDA approves a medication, there must be clinical trials. So let's talk about drug responses. So there's the dose response curves. There's different types of drug responses. There's drug selectivity, and there's brand versus generic, and the drug responses in the real world. And we'll get into all of this. So first thing we want to talk about is the drug dose relationship. So the dose-responsive curve is the relationship between the drug dose and the magnitude of effect. Does that make sense? Doses below the curve do not produce a pharmacological response, and doses above the curve may lead to unwanted effects, such as drug toxicity. So there are two types of responses. One is quantal, and that may or may not occur. There is a graded drug response, and that is a biological effect can be measured continually up to the maximum responding capacity. Okay, so let me say that again. Drug doses below the curve may not produce a pharmacological response, and doses above the curve do not produce more of a pharmacological response, but may actually cause a toxicity. So it may lead to some unwanted effects. So you may think, okay, I'm just going to give them more and more medication because this is going to help. But actually, you may cause them to be toxic. So when you're selecting a drug, think about the ratio of the dose producing undesired effects to the dose producing the desired effects. So you want to consider the minimum effective concentration, which is the level below which therapeutic effects will not occur, or the minimum toxic concentration effects will not occur. So, and you also look at the therapeutic index range, which is the MTC to the MEC. So the minimum effective concentration is the level below which therapeutic effects will not occur. And the minimum toxic concentration effects will not occur. So these are both still minimum. Brand versus generic. Some patients are like, I'm not taking generic. I don't want that. Give me the brand name. I want the brand name. The differences are in the inactive ingredients. So for brand, it has 100% active ingredients in brand drugs, and inactive has active ingredients in generic. So the differences are the inactive ingredients. Brand and generic drugs contain the same active ingredients. However, there is a difference in the inactive ingredients. In the U.S. Food and Drug Administration, or the FDA Orange Book, rates generic substitutes for brand name products. So if you ever want to know how a generic is rated, you can go to the FDA Orange Book for that. Okay, and now we're going to move on to receptors. So there's several different receptors. There's ion channel, transmembrane, there's enzymes, there's drug action that happens at receptors, there's disease states of receptors, non-receptor mechanisms. So we're going to go over a little bit about drug receptors in this introduction, okay? So first, there is the drug receptor interactions. Most drugs work by binding to receptors. And receptors are located on the cell surface. So the drug molecule must fit into the receptor. So it's kind of like a lock and key effect. So remember that drugs work by binding to receptors, and receptors are located on the cell surface. And it's got to be like a lock and groove or a puzzle piece. That drug molecule must fit into the receptor. So when we talk about drug receptor binding, when a drug receptor is graded, the more receptors filled, the greater the pharmacological response. A drug receptor binding is reversible. A drug receptor binding is selective, and a drug receptor binding is graded. And again, when a drug receptor is graded, the more receptors filled, the greater the pharmacological response. And drugs that bind to receptors can be agonists, partial agonists, or antagonists. So pharmacokinetics is the absorption, distribution, metabolism, and excretion. Those are principles of pharmacokinetics. So let's go and talk about each one a little bit. Absorption. So there's different ways you absorb, which could be by oral. It could be the site of administration, especially if it is an injection. And so absorption affects bioavailability of the medication. It also affects peak blood levels. So we absorb it that way. How is it distributed? Well, movement of the absorbed drug in bodily fluids throughout the body to target tissues. So the movement of the absorbed drug in bodily fluids throughout the body to target tissues. This requires an adequate blood supply, right? So you got to be living, blood has to be moving and flowing for anything to be distributed. Drugs move to areas of high blood flow first, right? I mean, it's easier. It's not going to go to where the blood's. Think about a patient with like a necrotic foot versus a healthy patient, maybe a young runner, good feet. So think about the blood supply being distributed to the patient with that necrotic foot versus just a young, healthy person. The drugs are going to move better in that young, healthy person's foot. It will get to that foot versus that person with a necrotic foot. Now, some properties that affect distribution, because it depends on an adequate blood supply, right? Water or lipid solubility, the size of the molecules, protein binding, and transporters. So there's different types of distribution. It can go through fat, bone, the blood-brain barrier, or the placental barrier. So if it's fats, well, lipid-soluble fats have a high affinity for adipose tissue and a low blood flow. And when we talk about bone, some drugs have an affinity for bone, like tetracyclines. They're deposited in the bones and the teeth. So when moms take certain medications or when young children are on some medications, it is distributed and it affects their teeth. So you'll see them have the yellowish brown teeth, especially children with febrile seizures who've been put on maybe Dilantin or, phenytoin. Well, then they have the stained teeth. The blood-brain barrier is relatively impenetrable, so that it's hard to cross the blood-brain barrier. That is usually protective. Only lipid-soluble drugs can cross the barrier. So remember, the blood-brain barrier is a protective mechanism, so it's really hard to penetrate the blood-brain barrier. Now, with the placental barrier, many drugs pass the placental barrier. It's got a low molecular weight drugs, they pass with ease. So when moms are pregnant, we have to be very careful in how we prescribe medications to them. So you'll need to understand this cytochrome P450 or CYP450 because it affects metabolism. The CYP450 is organized into numbered families. You won't need to know all these numbered families. There's no way we can remember all that. But they have the CYP1, the CYP2, and the CYP3. And different factors affect metabolism. So what are some things that probably affect metabolism? Age, right? Pregnancy. If somebody has liver disease, even the time of day. It could be genetic. There could be some genetically determined factors that affect metabolism. Alcohol. Somebody who's drinking a lot of alcohol. Maybe their diet is affecting the metabolism. Factors that influence metabolism. So there's chemical reactions in the liver. In phase 1, that is oxidation, hydrolysis, or reduction to increase water solubility of drug molecules. The majority of drugs are metabolized in the liver by the hepatic isoenzymes, right? So anytime patients are on medications, it's usually metabolized in the liver. And those CYP450 isoenzymes. Phase 2 is the conjugation or the union of the drug molecule with a water-soluble substance. So there's a chemical reaction in the liver, and it goes through 2 phases. So when we talk about prodrug metabolisms, what is a prodrug? That is a drug that is administered in an inactive or significantly less active form. It's a prodrug. It's usually inactive. It has to be activated. Once it's administered, the prodrug is metabolized in the body into the active compound. So you can think of it like this. I am taking a medication, it's inactive, I put it in my body, it activates. Simple as that. Prodrug, a drug that's administered in the inactive form, and then once it's administered and metabolized in the body, it's metabolized into the active compound. Very simple. Now, CYP450 drug interactions. So enzymes can be slowed. If they're slowed, it's considered inhibited, or increased, which is induced. And we need to know which medications can do that. And that is so many. We're not going to get into in module 1. I just kind of want to introduce you to CYP450. Concurrent therapy with an inhibitor or inducer may alter the metabolism of a medication. So that's why knowing if these drugs aren't working, maybe it's something with the CYP450 enzymes. So now we know how drugs are absorbed. How are drugs excreted? So renal elimination includes passive glomerular filtration. So removal of the drug from the body by the organs of elimination. Most drugs are eliminated by the kidneys. So how are most drugs absorbed? Where are they metabolized? And then where are they eliminated? In the kidneys. But drugs are also eliminated in the lungs, the GI tract, through sweat, in mammary glands, through saliva. So the renal elimination includes a passive glomerular filtration or active tubular secretion and tubular reabsorption. So what kind of factors do you think affect renal excretion? What would make the drug have difficulty being eliminated from the body if it's eliminated by the kidneys? Age, kidney function, right? If my kidneys aren't working, then the medication is not coming out. So kidney function is a big one. Hydration, your cardiac output, the GI tract. So after being metabolized in the liver, the metabolite is excreted into the bile. Some drugs may then be reabsorbed in the intestine through the enterohepatic cycle. So if we talk about lungs, that's through gases. General anesthetics, so medications could be excreted through there. The rate of excretion would be based on the respiratory rate and the pulmonary blood flow. So when we talk about sweat or the salivary, not very many drugs are excreted that way, but that could explain why patients complain of that yuck taste in their mouth with certain drugs. Then we talk about the mammary glands, which is, the breast milk. Many drugs are excreted in breast milk. So you have to be very careful if you're prescribing to a nursing mother, because what she's taking in, that baby may be getting in certain percentages. Okay, we will move on to rational drug selection. So, what is rational drug selection? Well, the process of a rational drug selection is prescribing, right? So you have to define the patient's problem, which could be by assessing the patient, developing a working in differential diagnosis. And you would use diagnostic tests to confirm and specify the therapeutic objective. You may collaborate with the patient because the patient is important. They know what's going on with them, so you can't count them out. The process includes educating the patient and monitoring for effectiveness. You want to know what's the goal of treatment? Again, talk about this again. Am I trying to cure a disease? Am I trying to relieve the symptoms of the disease? Am I trying to replace some kind of deficiency like insulin? Maybe I'm doing some kind of long-term prevention, but you do have to collaborate with the patient. The World Health Organization recommends including the patient in developing the therapeutic objectives of drug therapy. I can tell you, if your patient's not on board with what you're prescribing, you can prescribe everything that you want. That patient's not going to take it. So you have to get your patient on board with that plan. If your patient is really skittish about taking a medication, they're not going to take it, no matter how much you talk about it. But if you educate them and they understand, well, you might be able to get them to see, okay, this is going to help me, but it's going to take a lot of education for that. So when you're choosing the medication, use evidence-based guidelines. Evidence-based. Don't go on social media. Don't take chat groups. Don't worry about what somebody else is doing. Know that you are prescribing using evidence-based guidelines. They're individualized for every patient. It's not cookie cutter. Consider the pharmacokinetics and pharmacodynamics of the drug and determine the cost of effectiveness. So, new providers usually use like an analytical step-by-step decision making, whereas experienced providers use experience and pattern recognition. And what do I mean by that? Well, I've been in this game a long, long time. I know which medications I like to prescribe because I stick to a certain ones. Does that mean what I choose is better than what you choose, or what you choose is wrong and what I choose is right? No, it means that I prescribe these medications for certain disease processes because I've seen them work. They're my tried and trues, so that is my pattern, and that comes with experience. But you will need a more systematic approach with some of those complex patients. So when you're prescribing, think of this mnemonic. I can prescribe a drug. What is the indication? What is the contraindications? What precautions do I need to be thinking? What about cost and compliance? The efficacy of this drug? Are there any adverse effects? I need to know dose, duration, and directions so I can prescribe a drug. When you are educating your patient, know that poor adherence contributes to worsening of disease, hospital admissions, and death. So they need to understand, and you need to make sure they're adhering to these medications. Patient education. I know this sounds horrible, but it should be at about a fifth or sixth grade level. Don't go in there prescribing to or educating your patient like they're on the same level. And it's not demeaning to them. You just want to make sure they understand. You want them to understand the purpose of the medication, how to take it, so instructions for administration. And you also want them to know what adverse drug reactions or ADRs to look for. And after you prescribe, you want to monitor effectiveness. So there's different ways to do that. There's passive monitoring. The patient is educated on expected outcome and instructed to contact the provider. So in passive monitoring, the patient is going to tell you what's going on. So you wait on the patient to report. But active monitoring, you follow up. You may do lab tests. You may do some kind of monitoring to measure therapeutic effectiveness. So that is active monitoring when you're actually doing things like labs or some kind of therapeutic monitoring. Passive monitoring is more letting the patient tell you what's going on. Drug factors that influence drug selection. So we think about pharmacokinetic factors, the ease of titration, and the therapeutic index. So that's a drug factor influencing the selection. When we talk about pharmacodynamic factors, that's the distribution or the ability to cross the blood-brain barrier. What about the CYP450 metabolism? That's a pharmacodynamic factor, right? What about renal elimination in their kidneys? Are their kidneys functioning right? We talk about the dose concentration curve and the half-life of therapeutic effects. A narrow therapeutic index is more difficult to manage. So like lithium has a very narrow therapeutic index and a patient can get toxic very, very quick. So you really have to measure them and you have to dose that very, very slow. It is difficult to manage. Some providers won't prescribe it because they don't want to deal with it, but lithium works very, very well and should be used. A wider therapeutic index is safer and it requires less monitoring. So think about the safety profile, which varies by population. Remember, pregnant women with the teratogens. So you think about them if they have liver or renal disease. You got to be careful of those patients. What about if they have a drug allergy? And then the cost. High drug costs by the patient, it's probably going to decrease their adherence. They ain't buying it. So you think about patient factors like have they ever had an adverse drug reaction to a medication? What about their health beliefs? Some patients will not take medications because I'm not taking that. Their age and pregnancy. You may need to consult a pharmacist regarding complex drug regimens. Don't ever feel there's any shame in the game to contacting a pharmacist to ask some questions. The ease of prescribing or monitoring. Remember, NPs need to be familiar with formularies they're allowed to prescribe. So your patient may be coming looking for some medical cannabis. We can't prescribe that. You may have a patient that comes in and wants phentermine for weight loss. We can't prescribe that. So you need to know what formularies you can prescribe, okay? And over time, you're going to develop a small list of drugs that you're comfortable prescribing. Sometimes drug reps tend to influence the drugs that we're selecting. Way back in the day, they used to bring lunches and gifts and all this kind of stuff. And of course, they had these fancy pins and these mugs and koozies, and you were probably going to try and use that drug because you saw all that paraphernalia. Now they just bring you out to dinner. But at one time, they were very instrumental in changing how we prescribe because we wanted to try their drugs. We got to know them. It's like, oh, I'm going to try this. But not so much right now. When the recommendations and guidance change, you need to be aware. So you need to be coached, re-educated regarding appropriate prescribing. So remember, it won't end in this course. It will go on. Okay, and we will talk about adverse drug reactions. So an adverse drug reaction is any undesirable or unintended effect occurring after administration of a medical product. So there's two types of ADRs or an adverse drug reaction. There's the pharmacological, which is about 85 to 90% of the adverse drug reactions. And there's idiosyncratic. That is unpredictable. Every drug has the potential to cause harm. Every drug. And adverse drug reactions are unintended. And they could be unpredictable. But some adverse drug reactions may be predictable, like hypersensitivity reactions. There is the type 1 immune-mediated reactions. There is type 2, which is antibiotic-dependent reaction. And there's type 3, which is the immune complex or hypersensitivity. And you won't have to know those per se like that, but we will talk about the different types so you understand what happens when, okay? So, in the type 1 allergic response, that's an anaphylactic reaction. It's going to happen right away. That can happen in a previously sensitized person. And it can be fatal if it's not treated. So type 1s, think about the anaphylactic. Type 1, worst kind, anaphylactic. Immediate response. Type 2, allergic response. That could be like the cytotoxin or an autoimmune response. So maybe somebody gets like an anemia from a medication. Maybe someone is taking a medication and their hemoglobin and hematocrit keeps dropping. Well, you need to investigate. Is it this medication that they've been on for a couple months? Quite possible. And usually if you take the drug away, then these symptoms start to go away. So someone who's gotten like a hemolytic anemia from a medication, we take that drug away and then they don't have that anemia anymore and their blood levels, their blood counts start to come up. Then you have the type 3 allergic response. That one, it feels more like a serum sickness. It takes longer. It usually happens in about 1 to 3 weeks after that drug. So maybe they come in and they're complaining like they've got fever and their lymph nodes are all swollen and they're feeling just really yucky. And you started a medication on them like maybe a week ago. Maybe you started some penicillin and now they're feeling like crap. So that is that type 3 allergic response. So they're going to come in, they're not feeling good. Oh my God, my lymph nodes are all swollen and I have fever. And you're like, well, you got to do some investigating, right? Maybe they have some angioedema. Like, what changed? You start investigating what has changed. It was a medication. And so this response is like occurring 1 to 3 weeks after that drug exposure. And the type 4 allergic reaction, that's a cell-mediated. It's like a delayed hypersensitivity. Usually there is like some kind of hives or something, like a common skin reaction. And that can happen like 24 to 48 hours after the drug has come in contact with the skin. So again, when we're talking about adverse drug reactions, there is the pharmacological, the idiosyncratic. It could be a result from chronic medication use, delayed reactions, or it could be treatment failures. So time-related adverse drug reactions, that's rapid reactions. Okay, it could be first dose reactions, early reactions, or it could be intermediate where it doesn't happen right away. You could have some late reactions. Delayed reactions of dose-related ADRs can occur. That could be from an excessive dose, not adjusting the dose for age or organs like, kidney or liver failure. And serious adverse drug reactions can cause hospitalization or death. So they could have serious, they could have a moderate reaction, they could even have a mild reaction. So, how do you predict if someone's going to have an adverse drug reaction? Well, it's really hard. You really can't predict. But some people are more predisposed than others, like those with genetic factors. So, maybe if mom was allergic to penicillin, it's highly possible they could have a child that's allergic to penicillin. Age, usually we see a lot of reactions in young kids. Body mass. So, when you're prescribing a drug, the average drug dose is calculated based on using an average weight of 150 pounds. So we never really think about that. So any kind of drug, the average dosing is based on an average weight of 150 pounds. Children are dosed in milligrams per kilogram, which you guys all probably already know that. Morbidly obese patients need dose adjustment of some medications due to the distribution of the drug. So you always have to take these factors in when you're prescribing. So think about children. If they're very thin, then you may have to decrease the dose of medicine that you're giving because they have the body type like a pediatric patient. Or if they're very obese, they may require medication adjustment. They may need something more. Something I don't have listed here, but if someone's had like gastric bypass, you have to adjust medication for that. Some medications you can't give, and some you have to give in different forms. So when we're talking about predicting adverse drug reactions, women tend to be smaller. They have a different fat distribution, and they can get pregnant and have these pregnancy changes. Drugs may affect mood and behavior. Maybe different temperatures like low oxygen or temperature changes also affect drug reactions. The time that they take it, like if they have to take it with the food or they don't. Anxiety may produce a resistance to anti-anxiety drugs if they have problems with their kidneys or their liver, so their pathological states also. If you're giving medication during pregnancy, you want to weigh the risk versus the benefit, or the benefit versus the risk. Oftentimes, providers are very skittish about providing to pregnant women, but you have to consider the benefit versus the risk. Some women in mental health don't want to take their medications. However, if you take that medication away, what is the risk to the patient? Or what is the risk to the baby and the benefit to the patient? Does that mom still need to be on medication? Depending on the type of medication, quite possibly so. So, how do we respond if somebody's having a reaction? You might need to stop the drug, but if it's medically necessary, you might have to be very careful and continue it. Or you may have to do a re-challenge to really confirm it is the drug that's causing that reaction. And we'll briefly go over special populations before we wrap up Module 1. Special populations are women and children in geriatric. So when you're prescribing to women, you are prescribing during their childbearing years. So you always want to be aware if there's a possibility they're pregnant. So once they've hit menopause, you don't have that to worry about. But anybody who's within childbearing years that has not been sterilized, you always want to know what's your last menstrual period. You don't want to prescribe a drug not knowing if that patient is pregnant or not. You always need to know that. Lactation requires careful prescribing. All women should be screened, of course, for the risk of violence. And you're like, what does that have to do with anything? Anything. Well, maybe their partner is sending them to get some medications for them. They're being abused at home and they're in here trying to get some benzos for the partner who's hooked on drugs. And women also have a longer lifespan compared with men. Sorry, guys. It's not me. Just telling you. And compared with men, the reason why women have their lifespan is changes in their cognitive and physical functioning. There's gender differences in pharmacokinetics. There's gender differences in drug metabolism. There's a faster clearance of drugs in women than men. So the female adolescents, we think about them being at risk. Female athletes for that triad disordered eating. So we have to be very careful. Some of them tend to overexercise, which leads to suppression of the hypothalamic pituitary ovarian axis. So they stop having periods. So there's definitely things with women that we need to consider, like the reduction in their estrogen levels, leading them not to have periods. They may have decreased bone mineralization. So if a female is having decreased bone in mineralization, the treatment is usually like with calcium and vitamin D and oral contraceptives if tolerated. So there are some pharmacokinetic changes in pregnancy. Drug absorption from the lungs and skin increases. They have increased plasma volume that affect volume distribution. The drug clearance increases. So they may have iron deficiency anemia, which is a concern, and they may need to have an iron supplement. The teratogens, there's risk for many, like from drugs, alcohol, and tobacco use during pregnancy. Caffeine use should be limited, and smoking any kind of tobacco that is affecting the oxygen availability to the fetus. And so most of those babies are low birth weight or preterm. And some of those moms even experience abruptio placenta. We really don't know a whole lot about using herbs during pregnancy because it's not well studied. So women going through menopause, you see changes are seen in menopause. There's reproductive changes. Of course, they're not reproducing. There's some musculoskeletal, some cardiovascular. They may have some cognitive impairments. Some of these require hormone replacement therapy. So either you can do that or you can send them to a specialist. In our pediatric patients, most oral drugs are administered. They're absorbed in the small intestines. Infants have proportionally larger small intestines, intestinal surface area, and infants have increased intestinal mobility. Newborns and infants have a higher percentage of body water. So there historically the perspective of pharmacokinetic differences in children, the developmental aspects of pediatric prescribing. There's different factors that influence positive outcomes, like some of that I've already talked about. It's very unpredictable absorption in children compared to adults. In pediatric patients, the blood-brain barrier is incomplete. Infants younger than 6 months have decreased plasma proteins available for drug binding. So when we talk about pediatric medication administration, so for infants, teach parents about medications. Teach them how to administer the medications. Toddlers and preschoolers, they're pretty independent, but you still have to administer their medication, but they may hold it to take it. In school children, we use higher concentration and therefore lower volumes. Okay, let's go over the geriatric patients so we can wrap this up. So there's different changes for them, demographics, physical changes associated with aging. There's the pharmacokinetic changes, pharmacodynamic changes, pharmacotherapeutic, there's transition of care and care settings. There is a lot of things that affect the geriatric population. And you want to go with the general principles of prescribing for older adults. This is the fastest growing segment in the US population is people 65 years of age and older. Even the population of patients over 85 is growing. One of the big things we have to be careful with geriatrics is polypharmacy. It's very common in the older adult population. And emergency visits for adverse drug reactions are very common in older adults, especially compared to younger adults. They go through mental changes, sensory changes, they have musculoskeletal changes. So their mental changes, they have increased susceptibility to delirium and cognitive side effects from drugs. Sensory changes involving their sight. So 1/3 of older adults have a visual impairment, and 1/3 have a hearing impairment, and then their smell and taste is diminished. So they start to lose weight, and you compound all of that with medications, and we've got problems and situations. Again, absorption is not dramatically different in older adults compared with younger ones. With distribution, there's increased fat stores and decreased body water and serum albumin. Their metabolism, they have decreased hepatic blood flow. And we kind of talked about this one already. Excretion, they have decreased renal mass and glomerular filtration rate. So serum creatinine is an unreliable marker of renal function, so don't only depend on that. In the geriatric population, there is a high risk for adverse drug reactions due to non-adherence, unsafe practices, the high prevalence of use of over-the-counter and herbal therapies, and polypharmacy. They usually use one drug to treat side effects of another drug, so it just goes on and on. Some of the general principles for prescribing for geriatric patients: get a complete history. Avoid a drug if benefit is only marginal. Evaluate the drug list for duplicates. Make sure you are looking, put eyes on that drug list or eyes on those bottles. Review for the drug list for adverse drug reactions, and try to prescribe some non-pharmacologic treatments if you can. You want to complete a drug history. I would say to visit every time they come in. Every time they come in, you want to look because they've probably gone to several other providers. So you can use the Beers criteria for the older population. The Beers criteria, they have start-stop tools. And so that's some criteria to avoid prescribing some of the harmful medications that have narrow therapeutic ranges. And in summary, older adults take more medications than any other age group. That geriatric population has that polypharmacy on lock. Pharmacokinetics and pharmacodynamics are altered in the geriatric population. Adverse drug reactions are common. The risk increase with a number of drugs used, so that polypharmacy is a problem. Non-prescription herbal therapies are common. Have some monitoring systems in your clinical practice. Lay eyes on those bottles. Okay, that is the end of Module 1.